We've got a couple of guest speakers today. We're grateful for them joining us. Dr. Estelle Harris is with us, and later in the call, Dr. Russell Vinnick will join us. He's been on the call before. Because we have kind of a full agenda, we're going to just give a quick update on things here at the University of Utah. We continue to be growing in numbers of COVID cases post Christmas. 76 current COVID cases in-house based on this morning's dashboard, and our critical care capacity is at 108%. So again, continuing to expand. We saw these predictions over the last couple of weeks, knowing that this would likely be the case, and we have seen that around the country, of course, as well. We continue to accept ICU patients on a case-by-case basis through the transfer center. But otherwise, I heard statistics this morning that through December and into the first week of January, all of our surgical cases have been fairly consistently being accomplished. We were less than 1% cancellation rate, although that may change here in the next week or two, given these numbers. So, as I mentioned, we have invited Dr. Estelle Harris to join us today, and I'm going to turn the time over to her quickly. Dr. Harris is a professor of medicine and works in the medical ICU, has been one of the main providers during this COVID surge over the last year, and has a lot of information from just personal experience. Dr. Harris and I live just a few blocks from each other, and she's a dear friend, and I really appreciate her taking the time to join us today. We've asked her to talk about venous thromboembolism and the thrombotic prevalence in COVID. And so thank you, Estelle, for joining us, and I will turn the time over to you. I think you're still muted, but you do see your slides.
Okay, can you now hear me? Sorry about that. So hopefully I won't make this too complicated or disappoint you guys, but the take home messages is what we usually do is what we should still be doing. There it goes, okay. So basically we start talking about thrombosis and COVID-19. The actual hypercoagulability is poorly understood. And if you remember from medical school, which we probably don't want to, Furchart's triad, which is the combination of endothelial injury, stasis, and a hypercoagulable state, is the most recent cause for thrombosis. We do know that you get direct endothelial injury with COVID-19. Sorry about the typo there. And then we also know that there are many things, including fibrinogen, clot products, which are reflected in D-dimer, neutrophil, extracellular traps, and hyperviscosity that are playing a role. In the mini series, which have so far been published, most of them obviously are case reports and case series, have shown high rates of venous thromboembolic disease, DVTs and PEs in COVID-19 patients, at least 3% of patients in non-ICU settings, and depending on the study, between 13 and 30% in ICU populations. Clearly, it's different if you're just waiting for clinically apparent events and then looking versus routine screening. And many of our hospitals, including the University of Utah, we really couldn't get ultrasounds and other studies in the unit at the beginning of our outbreak. If you do have access to the University of Utah Pulse site, there's a really good review by Dr. Mark Sephardi from his vascular group on the arterial thrombus case series of the 4 patients we've had to date at the University of Utah, and that was from December 22nd. If you look at thrombotic disease, there's micro and macro, and this is taken from a autopsy series of 7 cases that was published out of New York. And what you can see in the picture is it goes from very apparent clot, which they then show removed, as well as the white area of adherent clot. And then if you look in the bottom right under D, where the star is, there's clear evidence of micro thrombi in the actual capillaries and venous vessels of the lungs and the alveoli. So most of the pathology in the lungs appears to be platelet-rich thrombosis. and there is a microangiopathy and alveolar capillary microthrombi. But if you look in the kidney, the small bowel, the liver, the skin, and the heart, you see lots of in situ thrombotic events as well. So this is clearly part of what's going on in the COVID-19 patients. However, the biology is not unique to COVID-19, and I think that's really important. So this is a study from 2017, or review article, excuse me, looking at the immunothrombosis and acute respiratory distress syndrome, or ARDS, and the crosstalk between coagulation and inflammation. And as you can see, it points out here on the left, you can see your little lung in your alveoli. It then blows it up to a single alveoli, and then shows how in the actual blood vessels next to the alveoli, you have your activated neutrophils with the adherent platelets causing your adherent nets. You've got your platelets bonding to your P-selectin on your endothelial surface, as well as your von Willebrand's factor, and you get these areas of thrombosis. If you look at platelets and neutrophils in COVID-19, and these are two cartoons from recent publications looking at platelets and extracellular traps from neutrophils published by our groups at the University of Utah. On the left, basically, as you know, you get your infection, you get your generation of your inflammatory mechanism. But what most of you probably don't know is that platelets, although you were taught don't have nuclei, when they get born from the megakaryocytes, they take untranscribed message RNA, which can then be activated and turned into protein. And so you get altered platelet gene expression. And from that, you get increased platelet leukocyte interactions and increased platelet reactivity. And in the little capillaries and venules in the lungs, what you actually see is all sorts of factors, including von Willebrand's factor, IL-8, IL-6, TNF alpha, the D dimers, all of those things are flowing in the blood along with your white cells, your platelets. And then when the neutrophils get activated, they literally throw out their neutrophil nucleus and all of the chromatin and proteins associated with it. It's almost like a volleyball net with adherent and enzymes and proteins that will increase both killing virus and bacteria and, unfortunately, inciting local inflammation. And so you get the platelets and the neutrophils binding in that area, and you get a lot of acute lung injury. And so that's kind of, from a cartoon standpoint, what's happening in this area. Lots of the literature has talked about many of the biomarkers, including D-dimer elevated in COVID. And on the left, I've taken this from a publication looking at COVID patients with the percent of the patients having either a normal D-dimer or an elevated D-dimer based on the clinical phenotype. And if you look at those with critical illness, those with an elevated D-dimer were a lot more sick in the setting of COVID. That was true of thrombosis and acute kidney injury. However, if you look at discharged alive, those with elevated D-dimers are less likely to survive. But that isn't unique to COVID. On the right is an article from 2009 H1N1 epidemic, looking at the oxygenation index of patients, which is another way to look at the PF ratio. In this situation, higher is better, lower is worse. And as you can see from the graph on the x-axis having D-dimer, that if your D-dimer was higher, your oxygen was a lot lower. And presumably those with lower oxygen don't do as well and die. So this is not a new phenomena. One thing that COVID and H1 influenza have in common is a lot of times we were always taught previously with influenza, it's not the virus itself that gets the patient in trouble with the pneumonia and ARDS, it's the subsequent bacterial infection they get. With H1N1, we saw a lot of primary viral pneumonia and acute lung injury just from the virus alone. And clearly we also see that in COVID-19. So what about thrombosis as a therapeutic target in COVID-19? The questions that the literature and everyone's trying to ask is, can you identify who's at risk to get into trouble? If you can identify them, what biomarkers would you use? And how could you decide who gets what treatments? Who should get prophylactic treatment or intermediate dosing or full therapeutic anticoagulation? And which agents are more effective and what intervals? And then what are the risks and benefits? Clearly the biggest risk of therapeutic or prophylactic anticoagulation is bleeding, and the benefit is to decrease the incidence of arterial or venous thrombosis. Data, it's minimal or none to date. They're just case reports, retrospective analysis, and observational. But we as a group of physicians in this nation and in the world don't like to sit by and wait for the data. And so we've come up with a lot of theories and hypotheses. This is taken from, I just got to the internet and chose any random one. So there's no specifics here, but this is a random hospital protocol I took and got rid of all the identification stuff for patients with COVID. And this hospital wants you to take all of your COVID positive patients greater than 18 and look at their level of their D-dimer. And if they fall into a level with a rapidly increasing or high D-dimer and lung disease, they want you to actually use therapeutic anticoagulation, or at least intermediate higher dose in those patients. If you don't fall into that, they want you to use a higher dose prophylaxis. And they state on the bottom here that all ICU patients should have 4 extremity venous ultrasound every 7 days. That clearly is not standard of care. In addition, they talk here about having thromboprophylaxis at home to up to 40 days post-discharge. Again, not standard of care. And so we have a lot of situations where we're doing things with patients and putting protocols into place. And some of your hospitals may actually be doing this, but it's very clear you need to know this is being done without significant data. There are no proven studies to date. There are more opinions than data, although currently there are over 51 trials targeting anticoagulation in COVID-19 patients. 10 of those are evaluating therapeutic versus prophylactic low molecular weight heparin, and I'll talk about one of those in a moment. 3 are looking at platelet inhibitors, and several are evaluating the daily oral anticoagulants, and obviously we're awaiting published results for this. Okay. So if you look at this announcement press release from December 22nd, the NIH, which was a 3-network consortium, which we are not involved in, but many of our sister hospitals, including IMC, are, is the ACT IV4 trial. And they were looking at blood thinners as a therapeutic versus prophylactic in ICU and floor patients. And the section of the patients in the ICU that were critically ill was held and paused enrollment while they continued on the floor. And the reason being was that among the patients requiring ICU support, therapeutic anticoagulation did not reduce the need for organ support. So there was futility in having the patients get better, but it's still being evaluated, and there is a possible signal of some harm in this population as well. And so enrollment currently continues for the moderately ill hospitalized COVID patients, but not in the ICU group. I'm just trying to see if I skipped one. I did. So one thing is, what's the evidence for why we use DVT prophylaxis in patients with ARDS? First of all, this is taken again from H1 epidemic time. This is a study from 2009 looking at 71 patients, and they were treated either with systemic in about half or prophylaxis. In this study, 37 of their patients developed VTE, which when they compared that to a previous group, historically, it was 6%. And 31 of these patients had H1N1. If you look at the panel on the left, they're looking at thrombotic event-free survival. So the likelihood you would not get a clot as a Kaplan-Meier curve over days in patients who didn't have the H1N infection. And you can see that the patients who didn't have an infection and didn't get anticoagulation had a lower event-free survival than those with the anticoagulation, but it was not significant. However, in the second panel, if you looked at the group that had the H1N1 infection, it was significantly more likely that you would have no thrombotic event if you were on anticoagulation than not. So this is, again, not unique to COVID. It's just, I think we have a lot more patients, and there may be something about COVID that makes it higher. Okay, So what do societies recommend? The Critical Care Society recommends that acute and critically ill patients receive prophylactic anticoagulation with low molecular weight heparin, unfractionated heparin, or fondaparodox. And then a subset of that called the Anticoagulation Forum says consider intermediate dosing in high risk critically ill and non-critically ill patients. ASH, which is the American Society of Hematology, simply says that acute and critically ill patients should receive prophylactic anticoagulation with low molecular weight heparin. The same is true of the American College of Chest Physicians and in the American College of Cardiology. They also say low molecular weight or unfractionated heparin with insufficient evidence for routine therapeutic or intermediate dose anticoagulation. So what about using the intermediate dose? We've argued a lot about this at the University of Utah. I can tell you my bias is intermediate dose may be a good way to go. A lot of my colleagues argue that I'm not using my common sense and that there isn't published data to support this yet, but I did spend years doing basic science lab work on platelets and think theoretically it could help, but again, we have to wait for the data. But this is a study showing whether or not it was safe, published this year. They took 105 hospitalized patients with COVID pneumonia and they gave them low molecular weight heparin. They did intermediate dose, either if you had low creatinine clearance, 40 milligrams per day, if you had mid-range normal creatinine, if you had normal creatinine, 80 milligrams per day with normal body weight, and if you weighed more than 100 kilograms, they increased that to 100 milligrams per day. And this could be done as one time or split into BID injections. In almost 2% of the patients, they had major bleeding events. Nothing was fatal, but they were big bleeds, including big hematomas. And almost 7% of the patients required blood transfusions during this time. And they found that in the group greater than 85 years of age, they had a over 30% mortality. So those patients who were older did a lot worse. So this says maybe it's a little bit safe, but also there was bleeding. So what are we doing at the University of Utah? We are doing normal prophylaxis with low molecular weight or unfractionated heparin. If patients have renal failure, we will use heparin, usually at the 5,000, or if they have a higher body weight, 7,500 sub-Q Q8 dosing. If they don't have renal failure and they don't have low platelets or risk of bleeding, and they can use low molecular weight heparin, we will do the Lovenox or enoxaparin at 30 milligrams sub-Q Q12 for 100 to 140 kilos. And if they're greater than that, we'll go up to 40 sub-Q Q12. And obviously, if you have a known VTE, we would do therapeutic anticoagulation as usual. I did ask some colleagues at Intermountain, and some of them will go to a slightly higher dose of the BID dosing in the intermediate range. So I don't have an answer because there's a lot of things that aren't published yet, but I think as you're taking care of these patients, you should be doing, as we are, what we know works. We know standard therapeutic prophylactic anticoagulation works, and probably until we have data to suggest that we should routinely be doing higher doses or systemic, we should not increase the bleeding risks in our patients, and we should do the therapeutic dosing and prophylactic dosing as we always have. So with this, I want to say thank you and ask you guys if you have any questions, and I hope that was in-depth enough. If you want more data, there's some really good articles out there. Obviously, Up to Date is also a really good place to look.
Thanks, Estelle. I've got a couple of questions. I want to throw it out to our group. If there's some questions, you can certainly send them in on chat, or if you have questions just right out of the chutes here, let us know. Just unmute yourself and jump on. We've got Seth from St. John's. I don't know if that's just because you got your mic on. One question I'd ask Estelle, the breadth of thrombotic processes in COVID certainly extends beyond just venous thrombus. We get well, how far do you think the extent goes? Because I think sometimes we think that people having MIs and arterial thrombotic disease and a whole collection of thrombotic syndromes may or may not be attached to COVID. As you described some of the pathophysiology of that, from my many years in the ICU, it smelled a little bit of both a trauma hypercoagulable state, a septic hypercoagulable state. It's a little bit of a mixed bag of several different types. What are your thoughts, I guess, on what it mirrors most in our experience, past experience, and yours? And then secondly, what about the arterial thrombotic disease processes that are being attributed to this? And is that something that for these folks out in their hospitals, they ought to be watching for arterial and stroke and a number of different other things to be attributed to it?
Yes. So certainly, just looking at the chat at the same time I'm answering your question, if you have a diagnosed clot or presumed as best you can, you absolutely need to treat it as you normally would. We know in critical illness, I deal more with sepsis and less with trauma. Burns another area. There is definitely increased risk for MI, stroke, DVT, as you know, and we are still working on how to best treat in all those areas with normal literature. So I think standard is still the way to go, unless in your specific population you have data to help you more with that. Clearly, if your patient has history of coronary disease and they have stents and everything, you may want to continue their antiplatelet therapy. There's no recommendation of what to do with antiplatelet therapy in patients who don't fall into those risk groups. We also know from H1N1 that it seemed like those patients had an increased rate of clots, arterial and venous, and embolic events and strokes compared to other influenza patients we'd taken care of in the past. And we have some published data with platelets and the abnormalities of those patients from the H1N1 epidemic from 2009 and since. Having said that there is an increase, that doesn't answer what we can do about it. So I think a vigilance is really important. And as we now are saying to all of the people who come into our unit, especially the people who bear the ultrasound machines in cardiology and vascular, at almost a year in, we have good enough PPE and we can keep the technicians safe. So we should be in a situation that if you need to do a duplex or a cardiac exam or a CTPA, that hopefully the patients with COVID can be safely taken to or have those studies done locally and get the answers. So you have to have vigilance to look if you clinically think it's indicated, and then you need to treat them. However, we also know that if you take a patient with a central line and you do serial ultrasounds, you will find small areas of in situ clots near those lines, and it's not clear what they clinically mean. So I think you want to, if you're worried, diagnose it in your patient, but I'm not sure I would do routine every 7 days forearm ultrasounds unless some new study comes out to justify the cost benefit of that. So I think it's using good common sense, good clinical judgment, and then looking at your patient's risk factor. Clearly somebody who's had clots in the past is going to be at higher risk and may warrant a discussion about a slightly increased prophylactic dose or treatment, depending on how far out.
Great, thank you. Any additional questions? Just jump right in.
And again, just like your group, we're always willing to answer any questions and help anybody with clinical concerns in the outside hospitals.
Yeah, just along that line, Estelle, one of the things that I think we as clinicians, whether you're a mid-level, a nurse practitioner, a physician or nurse, there's a desire to do something. And this has been a disease that's been a little bit frustrating with that, especially out in our rural communities of our affiliate hospitals. There's a little bit of a pressure that I sense when I talk to the folks in my tele-ICU role of being frustrated that they can't do more or can't prescribe more. And the theme that I keep getting, and I hear you again today, is that we need to be really careful. One, and I appreciate your thoughts on this, and sticking with the tried and true things. And that's something that I think ventilator management is bearing out, and thromboembolic prophylaxis is bearing out, as you've mentioned today. We do have a couple of new things out there with regards to remdesivir, steroids, and monoclonal antibody. And you don't need to take too much time, but what would be your recommendations to folks that are sending people mostly home? We've even, we've had calls where we've had people going home on remdesivir, going home on steroids, because I think some of it comes from this pressure to do something.
I'm gonna take the weak person out and say I don't have good explanations on what to do on those you send home because I only do inpatient critical care. However, again, I'd be cautious. There are good criteria on who should get remdesivir, who should get steroids, and people who are at home and not on oxygen are probably not the right people. For people who want to talk about the outpatient monoclonal antibodies, the state health department actually has a site, and on yesterday's COVID update, Emily Spivak talked about the local criteria for using the monoclonal antibodies from Lilly and the combination from Regeneron that have been approved for emergency use. Each hospital system that's participating has a phone number that's published on that state health department website of how to call and see if you're a candidate and see if you can get treated. So that's one option. There are some outpatient studies as well in the Salt Lake Valley. I know we're looking at convalescent plasma in patients who have tested positive and are in an outpatient status. Beyond that, I really do think you have to go with tried and true. Now, I think at this altitude, our patients are a little more likely to have hypoxemia. And it turns out that pulse oxes are now relatively cheap and less than $30. So I think sending a patient home with a pulse ox and making sure they don't get hypoxic would be really helpful. Once they're inpatient, I do believe that if they do qualify for studies and you're a place that can do them, we should participate because again, that data is going to be helpful in the future for figuring out what can work. But know that those all contain placebo controls usually, and we do not have the answers yet. And lastly, yes, vent management, with the fact that pronine does seem to add a role in this patient population more than I've seen in other ARDS patients. It's the 6 cc's per kilogram tidal volume, high PEEP if you can use it, but a lot of these patients you can't. And the thing that Nate Hatton here, who's been doing a lot of our COVID work, has pointed out day after day is normally our ICU stay is short and our mechanical ventilation time is just a few days. But in patients with COVID, when they're intubated, they're often 7 to 10 days on the ventilator. So again, these things do not change quickly.
Great. That's a lot of really good information. We really appreciate you taking time out of your busy schedule to join us. As Dr. Harris has expressed, we are all very willing to answer questions offline and support you and your decisions as you manage these patients. You'd be proud of these folks, Estelle. They've gone from not seeing much of this to really actually caring for a lot of these patients in their hospitals and doing a really good job. I know you get the transfers that do come in, but they're often managed.
No, I'm very proud of them. And just know if you didn't take care of the patients locally, we would already be overwhelmed and unable to help in the sicker patients. So I think Utah, if you look compared to the rest of the country, has done a fabulous job in both their interhospital communications, their load leveling, and their sharing of information. So no, I think it's a fabulous network and we should continue to work together.
Great. So stay on if you can, and if you can't, we'll bring you back another time.
I have to run off to clinic, so I am going to run away, but thank you very much. And I don't know most of you, but it's very nice to meet you, and thanks for all you do. Bye.
Thanks. So we'll jump over to Dr. Vinnick, who just updated in chat, if you didn't notice, the Utah State website that Estelle was talking about, where you can get that information. He's posted up there for us. Thanks, Russell. And let's go ahead and turn the time over to you and look forward to hearing your thoughts and have a few questions already for you.
All right. Good afternoon, everybody. Thanks for joining. Just as a little brief introduction, I was on a call maybe 2 or 3 months ago, and so I asked Tad, I ran into him, and I said, "How are things going with the affiliates?" And he said, "Well, why don't you find out for yourself? Come join us." So thanks for having me. I'm one of the associate chief medical officers here, and my role has been in COVID planning and operations. And so basically where we are, and I just wanted to give you all a status update, but then I'd also like to hear from you and see if I can answer any questions. So as y'all are aware, we're generally very tight on beds, and we've been very tight on beds throughout this. Myself, Tom Miller, who's our CMO, and Kenzie Graves, who's our other CMO, who works associate CMO in planning and operations. We take Q3 call now so that we can assess our ability to take any COVID transfers. And when the ICUs get tight, we actually review all ICU transfers to make sure we're okay. And so fortunately, things have been doing okay for the last month or so. I'm not sure if Dr. Kimball gave you a status of where we are, but we had a nice dip around Christmas where our census dropped as low as maybe 30 active COVIDs plus recovered. And we've had an increase over the last couple of weeks since Christmas. Part of it, I think there's a bit of an artifact. I'm a hospitalist, and so I work every Christmas because it's a good time to get away from my family. But what I see every Christmas is people don't get admitted. People don't come to the hospital, and they delay necessary care. And so our census always drops around Christmas, and then the really sick people come in after Christmas and New Year's once their disease has progressed. So we saw that as well, and our census has risen up to about 60 or so COVIDs and another 17 recovered in what we use the CDC's definition for recovered, which is generally for severe illness greater than greater than 20 days. So right now we're in the mid 70s, which is lower than where our peak has been, where we've been in the mid 90s at our peak before Thanksgiving. And the ICU beds are pretty tight. We have our B50 ICU, which is our surge ICU, which has 22 beds. And this morning we were using all 22 of those for COVID patients. And then our medical ICU, I think 23 or so of 25 beds were taken. So we were at about 105% occupancy using those surge beds. We had a little bit of room if we had to move some medical patients into our CV ICU, we will do that. So just to give you an idea, that's kind of where we are. As I look at the numbers in Utah, I think they're stabilizing, and I'm expecting things to improve over the next couple of weeks. But I just want to give you an idea of where we are, and also just so you know how we're trying to manage this, because we want to maintain our commitments, and we intend to maintain our commitments to you all, so that we will take care of your patients when you can't. It's been incredibly rare that we get a transfer to the floor. Almost all of our COVID transfers are to the ICUs. We got some from Nevada last week when one of our regional hospitals was full, and we've gotten a few just locally when those hospitals were literally full and out of beds. And so what Dr. Miller, Graves, and I do when we're getting calls during the day and at night is we certainly maintain those commitments to our affiliates and those hospitals that we work with regularly. And I hate to say, but we do have to scrutinize when we get calls from Texas, and we've even gotten calls from as far as Louisiana. We maintain those commitments to you all that we need to do so. If on the rare case that we just don't have the beds and can't take your patients, we have a system in Utah that Dr. Graves and I have worked with the state and the Utah Hospital Association, where where we're all committed to help each other out. And if we can't take a patient, what we can do is activate that command center. And thus far, we've always managed to find a way so that whether it's Intermountain and one of their affiliates or the university and one of our affiliates, we find a way to make those happen for our regional and catchment area. I can't say we don't do that for Louisiana. We can't do that for Louisiana, but we do and will do that, and that's our commitment to you all. So with that, I'm happy to answer questions. If you have questions about the antibody, I'm happy to answer those too. I was on our state group that set up those criteria, so would love to hear how you're doing and answer questions.
Thanks, Dr. Vinnick. Again, unmute, feel free to jump in and ask questions. Looks like Nate Creer, are you going to join? Or is that just you moving? Okay.
I'm here.
Yeah, join in or join the chat. I have a couple questions for you, Nick or Russell. One of the things that we run into in our discussion on our weekly call is the discrepancy with the data that's out there. We hear frequently that hospitals are at capacity, and then we hear that they're taking patients. I've heard you talk a little bit in our internal meetings about how, and you talked a little bit, you referenced it a little bit today about how we can be well over 100% or with very few beds, and other hospitals like IMC may be having a little bit of a dip, and that kind of ping pongs back and forth, but the averages that are being reported to the state, which are sometimes delayed in their reporting, may not reflect that. Maybe you can comment on that just a little bit for what's being put out there on state websites and how to interpret that.
So what I can tell you is I feel pretty good about what we're doing in Utah, and that it's pretty reflective of what's going on. So we've all met as a group, and when the state started putting together these dashboards, we got to work with them and the hospital association. And so when we report capacity, it is capacity of our regularly staffed beds. So for example, we have 111 regularly staffed ICU beds. As of today, I think we had around 116 patients in those 111 beds. And that means we've got 22 patients in our B50 surge ICU. And then their other ICUs are not quite full. And so that's how we get to those numbers. And that is something that all the hospitals, or at least the major hospitals in Utah, have committed. That's how we are going to report capacity, so that it's very clear where we are relative to what we normally staff. And we all do maintain, what is surge capacity? That's a hard thing. And I can tell you the CDC, those of you all who have gone into HHS portal and filled out those forms, it is very unclear what they want as far as their reporting. The way I interpreted it for the CDC and the HHS Protect is they said, we want you to include all surge beds in your total capacity. So when we did that, we told HHS we had 180 something beds. And that meant we were literally all but 4 of our operating rooms and double bunking, pay 2 to 1 in every operating room, plus using all 20 beds in our PACU. And that's how we came up to that 180 beds. So it gets messy. The HHS definitions are not clear. And I've read them about 10 times, and I can see how different hospitals can interpret those definitions differently. And so that's part of the problem. Whereas the Utah numbers, we've gone over those many, many times, and I think we're all reporting them the same. And they're usually about a day or two behind, so not too bad.
Great. We did have Emily Spivak come and talk about monoclonal antibodies about 3 weeks ago. I know that she spoke again on the 7th in our internal broadcast. Maybe you could quickly summarize, because that is something that our rural physicians are able to prescribe for outpatients and these more mild cases. Maybe just quickly summarize what may have come up in the last 3 weeks and what you would suggest.
Yeah, so a couple things that have come up. I'll tell you one thing that has not come up is good data.
Yeah.
So that's that. And in my career, I can't remember a time when I felt so much pressure from the government to do something that is not based on data. And it's we're getting it both from the state government and the federal government, saying, why aren't you prescribing more monoclonal antibodies? In Utah, our new governor mandated to the skilled nursing facilities, mandated to the health department that they need to find a way to give monoclonal antibodies in the skilled nursing facilities. And they've done that. One thing that we've found is very, very low utilization. We've been doing it now since probably almost 2 months now. And we've infused about 35 or so patients. And of those 35 patients, I think we've had 3 or 4, I think it's been 3 of them have been subsequently admitted to a hospital later. So that would be about a 10% admission rate. Our colleagues at Intermountain, they've done around 300, and I think they've had a 6% or so admission rate. Now that's in a population where in the state, we estimate that those patients, based on our modeling, those people were supposed to have about a 25% admission rate. That's not randomized data, but at least that's some degree of evidence that maybe there is more to this. And I've heard similar things, I think, from Mayo, that they've had a much lower than expected admission rate in these people who've gotten the antibodies. But once again, it's not randomized, and there's clearly some self-selection going on. The one thing that we did in the state is, because there's been such low utilization, we decreased our score that we would allow it to. Before, it was a score of 8 or above, which was expected to be about 10% of COVID positive patients would be eligible. We decreased that, before it was above 8, so 8.5 or above. We decreased that number to being above 7, so basically 7.5 or above. And that would be about 20% of the eligible population. What we're finding is there's a lot more drug out there than there is ability to infuse this. And as you know, this is hard to infuse. And we've set aside one area in our one of our infusion clinics that has private rooms. But despite that, we've gotten complaints from patients saying, I can't believe you're bringing COVID patients in to get infused. You should put them in a trailer or a tent. And so it's really hard.
Yeah. Dr. Symington from Wyoming is asking, is that admission rate due to progressive COVID symptoms or side effects of the infusions?
So that's all-cause admission rates. In fact, the majority of the admissions we're seeing are somewhat unrelated. We've had several cardiac-related admissions. But I think all causes is probably most appropriate to track.
Yeah. I wanted to take advantage of you being here, Russell, because you've become quite a statistician and epidemiologist with your slides on trending and we use your slides quite often just to show kind of the points in time where we are each week. And one of the ones that I thought was interesting, and I think it was one of your slides, was the influenza measurements. And what are your thoughts on this incredible evaporation of the flu in the face of what I assume is the masking, social distancing efforts and the lower transmission rate of flu just basically being stomped out by that?
Yeah, and I'm not an epidemiologist by any stretch, but so what Dr. Kimball is mentioning, we put together an influenza dashboard because we wanted to be able to track that. And since early November, We've done over 600 tests, and we've had 4 positive. So we test influenza in a various number of ways. Certainly we do the, every patient that we admit to the hospital that has respiratory symptoms, we do a biofire panel, which is a multiplex PCR. And then also, we certainly see in our ambulatory centers a lot of rapid flus being done. Of those 4 influenzas that were positive, they were all influenza B, and they were all done on the rapid tests. 2 of those, I'm convinced were clearly false positives. One person had gram negatives in her blood. Another one actually had COVID, and the other 2 didn't have a clear explanation otherwise. So maybe they were positive. So, not being an epidemiologist, my understanding, some of this decreased air travel from the Western Hemisphere might have helped, but also, so these things we're doing, physical distancing, mask wearing, are so effective, which is a great lesson to our patients and our public as well. And I think it also says how dang infectious COVID is. I mean, the fact that flu has not gotten a hold, but COVID is rampant, it just tells me a lot about that.
What number do you use? I've seen a lot of numbers about the comparative infectious rate of COVID versus influenza A or B. I've heard tenfold difference. What do you hear?
I don't know the answer to that one. That's a tough one, because to measure it is so hard. My understanding, and I meet with some of our epidemiologists every week or every other week, is when you're measuring it, it's supposed to be kind of at baseline, but then when we impose these restrictions, it makes it really hard to measure. So I don't know. I mean, the fact that we're seeing this much more COVID than influenza, my goodness.
Yeah, multiple fold more infectious. I think that's the clear message for us all is just, well, 2 messages. One is that respiratory spread viruses are impacted in a protective way by masking and social distancing and hand washing. And while we don't know exactly the difference between influenza and COVID, the fact that influenza has all but been eradicated, and we saw it in Australia in the summer, I use that as evidence to people who tell me that masking, amazingly, people who continue to tell me that masking is useless, that's just simply not true. One other question for you, that we are seeing, you use a slide also that shows the hospitalization rate per million across the country. It has round bubbles that in the Intermountain West, particularly Utah, has one of the lowest hospitalization rates per million, and yet we are in the top 5 in percent positives on testing and numbers. Give us your thoughts on that giant dichotomy there, that difference.
Yeah, great question. There's a lot that has to go into this. Why do we have such high positivity rates, but hospital per million is on the low side? We're probably in the top 10 in infection, but in the bottom 10 in hospitalization. Some of it clearly is age. Utah is obviously known for our young population. On the other hand, when I looked at average ages, like if you compare Utah to North Dakota, I think it's about 5 years. And it's just hard to think that is going to explain, a multifold decrease in hospitalizations. So I also want to give credit to our health department, what they have done as far as setting up strike teams in the care facilities to be able to rapidly test and isolate patients in care facilities. That there's a huge benefit there. What are the other intangibles? Those ones are just hard to figure out. I mean, there's likely other things going on. One thing that's happened in Utah that, for better or for worse, is our lack of too much public health measures has kept the hospitalizations pretty steady. Yes, we've had an increase, but throughout the summer we had a good number of hospitalizations when some states had very little. And I think ultimately that's going to come to help us over the next month or so, because so much of the population is now infected. We haven't achieved herd immunity, but if I just do the numbers and say close to 300,000 Utahns have been infected, are known to have been infected, and then we know from other studies there's about 2 to 3 unknowns for every known, that puts us getting close to 900,000 or so in the population that have been infected. So now our susceptible population is decreased by about 30%. That's not going to make it go away, but that's going to help a lot. And part of the question is, who are those susceptible? Are those people who, have we gotten through the people who maybe were at higher risk because of comorbidities or potentially just their social practices? And so my thought, and I'm not alone talking with some of our epidemiologists, we think that this will come to help us, and that we don't expect levels to get much higher. Maybe we've seen the worst of this and expect things to improve over the next couple of weeks, particularly as we start getting vaccines into the state. I heard yesterday I was on a call, about 2/3 of our skilled nursing facility residents have been vaccinated as of yesterday, with the intent to at least have offered the vaccine to all of our residents by next Tuesday, I believe. So all of those are going to come into play and help us.
Yeah, that was, you kind of went into my last question, and that was, having been in the mix of all this and talked with many people, seen all the national trends, all the data that you've run through your left ear and out your right over these many months. Your final slide always is that sort of that now graph where they're predicting actual versus predictive. And I noticed that it has this sort of peak in the next few weeks and then a very steady straight line down. Is that reflective of what you're talking about? That you think that vaccination and infection populations are going to kind of merge together, and we'll hit that? I know that herd immunity percent number runs all over the place, but that we're trending towards that, and that may be the final solution.
Yeah, I mean, that's what we believe it is going to happen. And it's, once again, our boss, Dr. Good, doesn't want us to talk about herd immunity, because that's not going to happen for a year or more. But depletion of the susceptible population is a good guy that will help us. And whether that depletion is through infection or through vaccination, that we believe that we've started to see some of that effect actually around Thanksgiving. Then we obviously had a little bit of worsening because of all the social gatherings that happened over the holidays. And hopefully as we get into the steady state through the holidays, and then really in the springtime when people are more outdoors, then we'll really be in a lot better shape. But what we also learned about this disease is humans are humans, and the minute they hear things are improving, their behavior changes.
Yeah.
And so there's going to be ebbs and flows for sure.
We have one of our guests that's joined us, Dr. Vinnick, Shauna Butler. She spoke on the Zoom call a few months back, and she spends a lot of time in healthcare and healthcare policy. And she's posted a question that says, are the contact tracing and wraparound services helping to keep hospitalization rates lower?
Yeah, I have to think they are. I honestly don't know to what extent our health department has been able to do contact tracing with the numbers that we've gotten. I don't know if anyone else on the call does. That hasn't been a question I've asked them. I know that they felt like when we were over 400 or so cases a day, they wouldn't have the ability to do good contact tracing. But I also know that they've added staff over the past several months. I'm not, I don't know, but I have to imagine that those types of activities certainly help, and different states have been able to do better than others.
I can tell you in the schools, every time I have a child in high school, we get, your child isn't considered exposed, but they were in a classroom with a patient. So I feel like school-wise, they're doing a really good job informing people on that front, I can at least say.
Yeah, and this is Shauna. I'll just add that across the spectrum, states and counties that I've talked to, and like I'm here in Texas, and again, huge state varying by, county, and all of those places where the contact tracing is robust and you have high levels of trust within your community or a closer knit community, and a contact tracer reaches out to you, they're seeing that it's really helping to reduce transmission. And then also it's preventing them from getting worse, so that they're managing the underlying problems, whether it's a diabetic or an asthmatic. So they're not coming into their hospital because it's really the wraparound services that are helping with that. So just a data point to help get this managed better.
Yeah. Yeah, thanks, Shauna and Jenny. Those are good comments. Maybe real quickly, Russell, your take on returning kids to school in the situation that we're in. We know there's actual, as you know, right now in the state of Utah, there's an actual lawsuit for this Utah school district to get kids back, and teachers are, I guess, on the other side of that, of course.
Well, I can tell you just from a personal perspective, I've got 2 elementary age kids, and they've been in school, and I felt comfortable with it, in part because I'm fortunate that my school has had a very proactive approach to distancing, and the kids sit outside when it's 10 degrees and eat their lunch on a bucket. And so they may not like it, but I do. But not every school is the same. Adam Hirsch, who's one of our, he's actually a primary children's infectious disease specialist, did a great live stream about a month or so ago based on this HERO study that they've been doing. And it's very fascinating, the data he presented, because in Salt Lake County, we have a live experiment going on where Salt Lake City School District has been remote, and then the other major school districts have been in person. And what they found is that for elementary age students, that Salt Lake City School District had a slightly higher COVID rate than the other school districts. As you got into junior high and high school, the school districts that were in person had higher rates than the one that was remote. And in the explanation, which I think makes a lot of sense to those of us who are parents, is in elementary school, things are really pretty well contained. And the kids do what they're told. Once you get into junior high and high school, the mingling that happens around school, not necessarily in school, is significantly more. And so even though we think that, oh, well, if they're remote, they're safer, that's not necessarily the case. If you're remote, then are your kids going to be in learning groups and actually have more interaction that's less supervised? And so I personally feel very comfortable with my kids because I know that they're in a safe environment, probably better than when I'm at home, when they're at home. And certainly if friends come over and I tell them to stay outside, they just don't do it. Anyway, that's it's a very fascinating evidence-based talk that Dr. Hirsch gave a few months ago. If anybody's interested, we can get a link.
Yeah. One final question, Dr. Vinnick, from that came up on the chat. With infectious populations being a part of the hopeful decline of the infection rate, Can you comment on the length of immunity of those infections and the importance of those who were infected to get the vaccine due to possible decrease in immunity at a later date?
So, I think that's a great question and an interesting question. And I think in medicine, we always talk about, well, there's no data that says how long you're going to be immune. And that's true. There is no data because we just don't know the answer. But I think the lack of data should be telling to us as well. That when you go into PubMed and you type in COVID reinfection, there are case reports. There are so few case reports. And so what that tells me is that reinfection is rare.
Right.
And it is extremely rare. And now we're almost, we're 9-10 months into this now. And so I think the likelihood is that the immunity probably lasts in the 10+ months for the vast majority of people. The people that I worry about the most are those who've gotten significant chemotherapy, bone marrow transplants. We've had a couple significant reinfections and deaths in those patients. And then I also worry about my relatives in South Africa, that they're seeing a lot more reinfections in that population. But fortunately, the South African strain doesn't seem to have made it here yet. But that might be a concern down the road. So many of you all saw our governor put out a executive order discouraging patients from getting vaccine if they've had COVID in the last 90 days. And as a physician, I feel comfortable telling our patients that that's very reasonable if you're within 90 days and probably longer.
Good. Well, we've had a great an hour. Really appreciate your time, Dr. Vinnick. And again, thank Estelle Harris for joining us with a tough question on thrombotic disease. And we will invite you back again. I know you're super busy, but we really—
Happy to.
Yeah, thanks again for taking the time. And we have so much more to talk about next week. We've got a bunch of questions on vaccine and vaccine interludes between the first and second dose. There's a lot of questions there that we plan on addressing next week. So be safe, continue the efforts in your community to be the purveyors of real data and real information. It continues to be a problem for us with the conspiracy theorists out there, and you're the source of truth. And we'll look forward to you joining us again next week. Thanks very much.
Take care, everybody.
Thank you.